Thank you so much for joining us for this month's CTEL Artificial Intelligence Working Group. We've got a couple topics, some updates in terms of AI policy, including some new requests for information that have been put out by CMS, as well as some activity on the Trump administration's nomination to lead NIST as well. And then after that, uh, most of our time, we will have Beth Jacobson join us to give a short presentation about AI and mental health and the solution for getting patients the care they need and decrease liability for AI companies. And then, of course, we'll have a membership discussion for any other topics and then some upcoming events as well. So first, there are two requests for information that I wanted to highlight in case this is something your organization might want to respond to. The first is a request for information regarding a new initiative from CMS called Comprehensive Regulations to Uncover Suspicious Healthcare, what they're calling CRUSH. And this is part of the administration's broader efforts to address program integrity concerns. And the administration is leaning pretty heavily on AI for this. And there are a couple items in this request for information specifically having to do with AI, including what type of AI solutions are most effective for assisting coders with large volume of records, key features and learning capabilities to improve accuracy, incorporate coder feedback, and prevent errors. Looking for information on how coding recommendations should be displayed to human reviewers, as well as compliance risks, lessons learned from implementing AI solutions, what current existing solutions exist that address coding issues related to overpayments and underpayments, as well as potential ways that AI could be used to increase the efficiency and accuracy of hospital billing. And so this is the first RFI that CMS has put out last month, as well as a more recent one that CMS is looking for information on AI tools for Medicare experience modernization. Specifically, CMS is looking for information regarding AI and machine learning services that are capable of enhancing the Medicare experience for beneficiaries across digital and voice channels, and solutions that can provide personalized plan recommendations, conversational AI support, predictive analytics, accessible decision support tools, and call center automation to help Medicare beneficiaries make informed plan choices and maximize their coverage. A pretty big portion of this RFI is more technical in nature, and it's looking for specific applications and solutions that AI could be used for these purposes. But this is also another AI RFI that CMS has put out as well within the past month. Any questions about either of these two?
No questions.
I'll also note that Doge has put out a pretty big package of Medicaid data um, on its new data warehouse that it's hoping that people will use AI to find new fraud patterns in that data as well. And so again, this is just another piece of the administration's efforts to integrate AI with its program integrity efforts. Another policy development that may affect the regulation of AI, not just in healthcare, but across fields, is the activity surrounding the nomination of Arvind Raman to lead the National Institute of Standards and Technology. He is an engineering dean at Purdue University, and he was nominated last year by the Trump administration to lead NIST. And he recently appeared before the Senate Committee on Commerce, Science, and Transportation, where he was ultimately approved by the committee, and his nomination has moved forward. He is not fully confirmed yet, but the approval of committee is a good sign for any nominee. He had his nomination hearing before the committee, where he pledged to carry out the administration's AI action plan, as well as affirmed a commitment to, quote, reorienting NIST to its apolitical mission and ensuring that it does not serve as an engine for divisive left-wing ideology, even under the guise of safety or increasing trust in technology. This came after the chair of the Senate Committee on Commerce, Science, and Transportation, Senator Ted Cruz, released his own AI policy framework last year and has shown a particular interest in increasing NIST's role in promoting the development and expansion of AI across fields. Any questions or comments here? And with that, I'll turn things over to Beth Jacobson to talk a little bit about AI and mental health. Beth?
Hi, everybody. Nice to somewhat see people virtually, that is. Hope you're all doing well. What I'd really like to talk about is something that you probably are aware of and seen in the newspapers with all the different lawsuits. But it seems as though much of the gap in access in care for mental health isn't really being filled by human providers, but rather AI agents, not by design, but by default. These agents are always accessible, they don't cost anything, and people feel very comfortable telling a chat box all about their different anxieties, their grief, or potentially confess suicidal ideations. But most chat boxes aren't designed for this purpose. Developers shape the terms of accountability through responsible design, or they face adverse verdicts, regulatory mandates, and legislative prohibitions that we're seeing across the nation. Plaintiffs are asserting claims based on strict liability under product liability claims, failure to warn, negligence, wrongful death, state consumer protection laws, a whole potpourri of different ways to try to attack these AI companies. The problem is the product was designed to be indistinguishable from a human encounter. That's what people really like about it. But without guardrails and ethical principles, you get into very adverse situations, like what happened in the situation with Rain versus OpenAI, AI, where it turned out that a minor was using the chat bot as a potential therapist, and then the AI chatbot told the minor how to tie a noose, and then he committed suicide. Obviously, not a result anybody wants, but somebody is going to be liable for this exposure. And the question faces, what can we do differently? So AI companies are trying to assert that they have First Amendment protections to do what they want in this area. But unfortunately, that's not really going to hold water because you're going to have these lawsuits by plaintiffs, like particularly parents whose children have suffered adverse consequences. And also, there's a volatile environment in terms of the regulatory hurdles that companies face on the state as well as the federal level. I believe that developers need to really architect a human in the loop for a solution rather than trying to master, if possible, their jurisdictional compliance gymnastics. This will be better for patients seeking care, and it will also allow AI to transform and do good in the world. So AI companies need to architect safeguards into their systems at the foundational level, not through disclosures and disclaimers, because I really feel strongly that juries aren't going to really give a lot of credence to the fact that there's a terms of service or disclaimers in fine print when you first started using AI. That just doesn't seem like it's going to do much protection for the companies. So what will this look like? I would propose that it would be the same principles that govern responsible triage in every other healthcare context. You have to know the limits of what your role is, and when your limits are reached, you transfer care to someone qualified to provide it. When an interaction on chatbot crosses a clinically meaningful thresholds, validated through established clinical scoring algorithms and pattern recognitions trained on comprehensive mental health diagnosis libraries, the platform should initiate an active, seamless transfer to a licensed mental health care provider. The legal logic of this design is equally compelling. If the LLM detects a crisis, successfully transfers the user to a live therapist, the platform has severed the chain of causation that plaintiffs must establish to prevail. This can create bridges to qualified human care that meaningfully addresses the mental health care crisis. I'm currently working on this product at Octave, where we are working hopefully to work with AI companies that will then seamlessly send a user who's in crisis actual therapists with appointment times that they can book through that are in network for those people. So I feel like this is a very timely product that's necessary for the users and also will help the AI companies in terms of their potential exposure in this area. So happy to answer any questions that you might have and open up a dialogue.
I
So
just put it on the chat, some sort of escalation, right? So you have a criteria that reads into when it needs to be done by a professional or when it is really sounding the alarm. This is something dangerous that needs to be addressed differently than just the chat. So yeah,
Yes.
I looking
Yep.
forward to see what that's going to look like.
Well, the nice thing about it is that if a person, and we've seen this now in a number of legal cases, when they continue to have conversations, the user, particularly minors, with the chat box, they oftentimes tell them it's okay if you want to kill yourself, which isn't necessarily the result any of us want to see. So it's either a handoff to a therapist, and the AI would stop conversing with that person unless they spoke to a human being. And also, it's just turned off so that they can't tell them, for example, how to tie a noose, because that's clearly no one wants that result. But it's really a seamless transaction so that we can expand AI, but just like in any other healthcare way, when it exceeds the amount of interaction that's appropriate, let's get you to someone who can help you in a meaningful way.
So can you give some examples of how they're training for this recognition? Obviously, asking how to tie a noose is probably going to be a bit of a red flag, but again, the development of this is going to depend on the programmers, developers, creators to say, don't tell someone how to tie a noose. That seems
Right,
pretty
right,
specific. I mean,
right.
are there standards that they're out there developing, or are there something that they can take from? Because this seems fairly novel.
Well, it's interesting. I'm not a psychiatrist or a therapist. However, what we've done is we've developed an LLM, and we have used established libraries of terms in this industry that trigger the need, in our opinion, for human interaction. So it doesn't ever get to the point where someone's tying a noose. It's much more when certain words are used together.
Hmm.
And we've had our I team help build this model for us. So it can be something that's just plug and play into the AI companies that it will spot what these words are and trigger reaction, which should be not in these words, but you should be talking to a human being. Here are people who specialize in if it's anxiety or
Mm.
grief. These are specialists, and these people, potentially are in your network. We would do it HIPAA compliant. So it's another way to help people who need the help to get the care. And unfortunately, there was a Harvard Business School study that showed of all the uses of AI, the biggest one is for people talking to AI through chatbots is about anxiety. So it's
Mm.
clearly being done. And I'm not saying that there isn't a place for it, but there's certainly a place where it gets to a point where AI is not a mental health therapist, which they clearly all say, but there needs to be a warm transfer. We would provide a bridge in order for people to get that care.
So
So
the
there's not a direct handoff. It's just a you should go talk to somebody else.
On their screen would be, for example, two or three therapists that specialize in their area with appointment times on the screen. So the person doesn't really have to
Hmm.
do anything other than click through. We're trying
Okay.
to make it as seamless as possible because the last thing you want to do is like, here's a list of names, and then the person has to start calling and see if they're taking patients and what insurance they take, etc. So this would be a really seamless way to integrate all of that so that somebody can get, usually when somebody's in crisis, they don't
Hmm.
want help in 2 weeks or 4 weeks. They
Right.
kind of need help now, and that's what we would provide.
Okay.
Would
Thank
there
you.
be a way to hand off to their local crisis intervention, like the mobile units, that could be dispatched to their location?
If that's necessary, yes.
Okay.
Yes. Yes. But basically, we're hoping that AI companies see this as a real solution, not only to help people, but frankly, from a business standpoint, move the liability off of their plate. We've done everything we humanly can do. We designed it so to give you the warm handoff. We designed it for you to get a therapist or a crisis intervention. And I think that juries would see that a lot differently than, we put something in the fine print when you first signed up to use our services. Because everybody knows nobody reads those.
Mhm.
And they're really just for legal cases. So I think this provides a service that I think that would be very meaningful to a lot of people. The other interesting point is that it would be in-network providers for the person with a quality metric score. So it would be quality therapist in network, which is really important as well. We don't want to just flood people with therapists that aren't good, but it would be quality metrics based on a scoring that we use, an objective scoring. So it'd be high quality in-network providers to try to give people the best care they can when they need it most.
Would you say this is the beginning of an evolution in this area, or this is a more of a terminal solution, for lack of a better term? Uh,
I think if you're asking, is this a new solution? I think it is.
mhm.
I think it really comports with a lot of what we're working on. We are trying to, Octave is built on the premise that people should be able to get high quality mental health care that's in network. So,
Mhm.
for example, I live in New York. There are therapists here where I live that charge $500 an hour. Well, most people can't afford that. That just seems like a lot of money versus
Mm.
doing something in network, but getting high quality. We're developing a way that people can not only get access through their insurance directories with this, but they can also see it in terms of the quality of a therapist and then book appointments directly through. I don't know if you've ever tried to, if you have insurance and you try to go to your insurance directory and get a therapist, you kind of have to write down all the names, see if they're taking patients, when do they have availability, and especially when you look at this in combination with ghost networks, it makes this seem like it solves so many problems. Because even if you stop doing AI, you wanted to get a mental health therapist, the directories are so difficult to track. And coupled with the fact that most of the people looking run into this ghost network problem. Emblem Health just got slapped with a $2.5 million suit based on not having therapists they said they had in their directories based on these ghost networks. So I think it's able to solve a lot of these problems.
Thank you.
You're welcome. Any other questions? Or Lydia, I can turn it back to you.
Great. Is there, if anyone has any questions or anyone watching the recording, or if anyone has any interest in collaborating further, is there somewhere that people can reach out to?
To me, absolutely. I'm on LinkedIn, and you can also reach me at bjacobson@findoctave.com. I'm always more than happy to talk to anyone, or Lydia, I'm sure people can reach out to you and you can give them my information if they'd like as well. I'll just give you my cell, 914-772-7024.
Great. Thank you so much.
Thank you.
And we have a few minutes left in today's working group meeting. Are there any other AI policy or industry issues that we haven't discussed today that anyone would like to ask a question about or comment on?
This is a question for those on there. I'm not sure if anyone saw um, the Epic settlement with Guard Dog, and there's a tie-in with Health Gorilla. So this is more on the telehealth side, but apparently their accusation being that Guard Dog, among others, has been taking patient data and feeding it to law firms to facilitate suits, and in the form of scrubbing Epic patient data files. So I think we're probably going to see a bit more on that, but I'm not sure if anybody else is closer connected than I am to that and has more insight.
I don't, but thanks for the heads up.
Yeah, it was only terrifying to read it.
Yeah.
That's really scary.
Well, the
Terrible.
thing that concerned me was in Epic's agreement with them, they estimate, I think it was 6% is what Guard Dog represents out of the total number of diversions that they believe are occurring.
Yeah, this is something that we've been tracking as well, especially um, as CMS and HHS work to um, further integrate AI and agentic AI agents with health records alongside their interoperability efforts.
Yeah. My mistake. It's they allege that it's the guard dog is responsible for 6,000 of the 300,000 records improperly taken by various companies.
And so the scary part about that is how many other companies have their hands on that data.
Hmm.
Frightening.
Yeah.
And with that, then our next monthly roundtable event will be hosted at the office of the American Psychiatric Association and will be focused on the DEA telehealth prescribing waivers and working on creating a unified strategy towards a long-term permanent policy solution for prescribing of controlled medications. CTEL members are eligible to join virtually. If you are, feel free to reach out to April or I, and we'll get you registered with the meeting link for this. And with that, that's all that I have for today's working group. Thank you so much for joining. Next week is our remote monitoring working group.
Thank you.
Thank you so much for the presentation and the dialogue.
Thank you.
Thank you.
Thanks.